بسم الله الرحمن الرحيم. استنادا الى ما اقره مجلس الكليه من جلسته التاسعه والمنعقده بتاريخ 8/1/2017 وبناء على توصيات الخبير العلمي واللغوي المدرس الدكتور مناقشة ساجدة ونظرا لاكمال طالبه الماجستير في فرع الصيدلة السريرية الصيدلانية دينا عباس حسين كافه متطلبات البحث والكتابه تقرر تشكيل لجنة القراءة ومناقشة رسالتها الموسومة تطبيق برنامج الرعاية الصيدلانية على المرضى المصابين بمرض اضطراب شحوم الدم في إحدى صيدليات المجتمع العراقي من السادة الافاضل مدرجة اسمائهم أبناء الاستاذ الدكتور ساجدة حسين دكتورة عضوا السموم ومتحدث رئيسا الاستاذ المدرس الدكتور ا.م.د الدكتور ا.م.د صديق الصباغ عضوا الاستشاري الدكتور حسين محمد عباس دائرة مدينة الطب عضوا والاستاذ المساعد الدكتور حيدر فخري هذه مشرفة. علما بان موعد المناقشه سيكون هو اليوم المصادر 9/12/2017 في تمام الساعه 9 يومنا.
Good morning everybody and thank you for your attendance. My thesis is entitled The Application of Pharmaceutical Care Programs on Patients with Dyslipidemia. Major functions for pharmaceutical care which are identifying, resolving and preventing drug-related problems. Pharmaceutical care process requires 3 major steps which are assessing the patient indication or condition and the drug-related problems, the care plan development to set the treatment goals, and the follow-up evaluation to indicate whether the patient condition is getting better or worse. Now, dyslipidemia is a state that occurs as a result of abnormalities in the plasma lipids, which could be presented as elevation in plasma total cholesterol, total glyceride, elevated LDL levels, or reduction in HDL levels. These abnormalities could occur in either singly or in combinations. Epidemiology of dyslipidemia. The prevalence of dyslipidemia is increasing worldwide, and this is due to the modernization and the socio-economic changes with lifestyle changes. About 80% of lipid disorders are related to diet and lifestyle, and 20% are related to genetic factors. Diagnosis of dyslipidemia is mostly asymptomatic disorder. That's why we rely on laboratory analysis, lipid profile, complete lipid profile, total cholesterol, LDL, HDL, and triglyceride. Also, history and physical evaluation may be needed. Management of dyslipidemia, we should always start with non-pharmacologic treatment, which means lifestyle changes, which include smoking cessation, dietary changes, weight loss or weight management, and physical activity. Then the pharmacological treatment may follow with, and 5 main classes of lipid-lowering agents are available: statins, bile acid resins, fibrate, nicotinic acid, and cholesterol absorption inhibitors. The pharmaceutical care represents an ideal area where pharmacists can add to the patient care for a number of reasons, which are about 45% of total mortalities in the Arabian Gulf are attributed to coronary vascular or cardiovascular disease. Many of these risk factors for cardiovascular diseases are modifiable, like dyslipidemia, hypertension, diabetes, obesity, sedentary lifestyle, and smoking. Also, these risk factors are widespread in Arabic communities. Pharmacist services are widely accessible and readily accessible to the healthcare providers and to the patients. Also, pharmacists can increase patient compliance and improve treatment outcomes. The present study was designed to apply a pharmaceutical care program within community setting and examine its impact on patients' knowledge about the disease, disease control, quality of life, adherence to therapy, and drug-related problems. Subjects and methods. This is a randomized, controlled, prospective clinical trial with a treatment and follow-up periods of 16 weeks was carried out in a community pharmacy in Baghdad city. Initially, 76 patients who were already being treated for dyslipidemia participated in this study, but only 57 completed the follow-up and laboratory tests. These 57 patients were randomly distributed into 2 groups depending on whether they received the pharmaceutical care or not.
So we have the intervention group and included 28 patients who received pharmaceutical care, while the control group include 29 patients and received the ordinary or the usual care. The inclusion criteria, patients included in this study if they met the inclusion criteria, which are if they are adult, male or female, already being diagnosed and treated for dyslipidemia and expressed the willingness to abide by the rules of the study. The exclusion criteria, patients excluded if any of these criteria produce, like communication difficulties, pregnancy, hypersensitivity to any of the lipid-lowering agent, or would not be in the geographic area for the entire period of the study. Baseline measurement and assessments. Patients in both groups were interviewed by the pharmacist to collect the baseline or the demographic data. Also, blood pressure measurement, weight and height to calculate body mass index. Laboratory analysis to measure lipid profile and fasting blood glucose for diabetic patients. Heart risk calculator to estimate the 10-year risk of atherosclerotic coronary vascular disease was also calculated. Patients' knowledge about dyslipidemia, the quality of life was assessed using a number of questionnaires. Drug adherence and drug-related problems were also recorded. Pharmaceutical care intervention and the usual care. Patients in both groups were surveyed for 16 weeks. During this time period, every patient was interviewed on a scheduled visit by the pharmacist, and this monthly visit for the control group include assessing for the drug adherence and laboratory analysis only with little or no education and without any empowerment for the patient for his participation in his disease management. While the intervention group of a stepwise pharmaceutical care program was developed for each patient, patient education on different aspects of the disease, its complication and management, behavioral modifications and recommendations regarding lifestyle changes, drug adherence was assessed and laboratory evaluation. Blood pressure and weight measurements, all these parameters were measured at every session. The final measurement and assessments was the same for both groups, where questionnaires were delivered to the patients to assess their knowledge about the dyslipidemia, quality of life, and medication adherence. Again, blood pressure and weight measurements was done, laboratory tests, drug-related problems. The patients in the intervention group received an additional questionnaire to measure their satisfaction about the care being provided to them. Statistical analysis was performed using SPSS and Minitab GraphPad software package, and the p-value considered to be significant if it was less than 0.05. Two samples t-test was used, one-way ANOVA, Mann-Whitney, and also Friedman ANOVA. Cohen's-Kappa analysis of the agreement to measure how is there any agreement or disagreement, and the magnitude of similarity between two discrete variables. Results. This is the socio-demographics data, and which was recorded at the baseline, and there was no significant differences between the two groups in their age, body mass index, sex, etc. Baseline disease characteristics, which include duration of the disease, lipid profile, atherosclerotic coronary vascular disease at baseline. The parameters there were no significant differences between the two groups except in total cholesterol, triglyceride, very low density lipoproteins. That's why an adjusted analysis was performed to exclude such confounder. Comorbid diseases. The diabetes was the most frequent comorbidity presented in our sample, and followed by hypertension. Assessment of the given therapy. The guideline we depend on in this during this study was the ATP4 guideline, which was published at 2013. And in this table, we compare the potency of the statin already being used by the patient at the onset of the study and the potency of the statin required for the patient. And there is a wide gap between the guidelines and the daily practice. Many patients were either receiving excessive dose or in subtherapeutic doses. This figure assesses the patient's knowledge about dyslipidemia from baseline to the end of the study, and the general knowledge in the intervention group was increased significantly, and all the domains of knowledge was also increased, while in the control group some aspects of knowledge were increased and some of them were decreased. Quality of life. Our results showed that even though the quality of life in the intervention patients was increased by 4 folds when compared to the control group, this increment was not statistically significant. Drug adherence, which was assessed at each session, that means on monthly basis, and also, although the adherence was improved in the intervention group along our study, but also again the adherence did not reach the significance level. Now, the effects of our pharmaceutical care program on clinical parameters and disease control. The effects on cholesterol, LDL, triglyceride, and VLDL, all these parameters were significantly improved in the intervention group when compared to the control group. And here also the fasting blood sugar, diastolic blood pressure was improved significantly, whereas HDL and systolic blood pressure were not improved in the intervention group. Drug-related problems in the study subjects, also there were significant reduction in the number of drug-related problems at the end of the study in the intervention group. And our program has resulted in the resolution of more than 50% of the initial problems presented in our sample. Patient satisfaction with the program was assessed, and the patients were highly satisfied with the services being provided by the pharmacist. Now, conclusions. Pharmacist interventions provide significant contributions in the reduction of the following parameters: total cholesterol, LDL, triglyceride, VLDL, body mass index, and fasting blood levels, providing better disease control. The application of pharmaceutical care program resulted in more than 50% reduction in the number of drug-related problems. Patient knowledge about the disease was also enhanced in the intervention group. The advantages of such a program with patient-centered actions were not limited to clinical outcomes. Some humanistic outcomes, such as patient satisfaction, was also improved. The application of the program had improved the quality of life, but the improvement was not significant. And although patient adherence was improved along the study course, its improvement did not reach the significant level. Recommendations. A larger scale multi-site clinical trials are required in Iraq to be more representative statistically. Longer study periods are needed to find out whether the positive impact would be preserved or not. Further research is necessary to assess the cost of such interventions, and other studies are important to evaluate the impact of pharmaceutical care services on other chronic diseases. And finally, thank you.